Hello everyone, Assalamualaikum. We are from Group 9 and we will be presenting about immunomodulatory drugs for oral diseases. So, immunological diseases affecting oral cavity are usually treated with steroid. However, when steroid is consumed for a long time, it may cause certain unwanted side effects, or it may also no longer enough alone to remedy the diseases. Thus, immunomodulatory drugs can be used to regulate or normalize the immune system. There are certain conditions whereby immunomodulatory drugs can be advised, which are when there are no response to corticosteroids, or the cases where corticosteroids are contraindicated, cases resistant to steroids, recurrent cases, or cases with the previous history of severe adverse effects with steroids. There are two types of immunomodulatory drugs, which are immunosuppressants and immunostimulants. So from the name, we can understand that immunosuppressants are used to suppress the immune system, while immunostimulants are used to stimulate the immune system. So let's go to immunosuppressants first. Immunosuppressants are agents that are used to suppress overreactive immune system that is causing damage to the host. These agents can be used in patients with autoimmune diseases or patients with hypersensitivity. There are various ways to classify immunosuppressants, either by the types or by their mechanism of actions. So these are three types of immunosuppressants, which are traditional, steroid-sparing, or biologic agents. Traditional immunosuppressants include drugs under the group of glucocorticoids, which are synthetic corticosteroids. Steroid-sparing drugs are non-steroid drugs that may permit partial or total withdrawal of corticosteroids. Last but not least, biologic agents, which are medicinal products manufactured or extracted from a biological source, such as plants or animal-based. So our presentation today would classify the drugs based on the mechanism of action of the drugs, which are inhibitors of lymphocyte gene expression, inhibitors of lymphocyte signaling, cytotoxic agent, cytokine inhibitors, antibodies against specific immune cell molecules, and inhibitor of immune cell adhesion. Okay, firstly is inhibitor of lymphocyte gene expression. Drug example is glucocorticoids, and the drugs under this group are as listed. And the most common drug would be prednisone, dexamethasone, and also budesonide. And these drugs work by inhibiting inflammatory mediators release, such as prostaglandin, from many cell types that are involved in inflammation. And when immune mediators are inhibited, immune system and inflammation would be suppressed as well. And this drug is indicated for various immunological diseases affecting the oral cavity, and as listed, it may be used for oral lichen planus, oral submucous fibrosis, recurrent after stomatitis, pemphigus, pemphigoid, erythema multiforme, Stevens-Johnson syndrome, and also toxic epidermal necrolysis. However, a thorough medical history of patients should be taken because it is also contradicted with various medical diseases. Okay, next is inhibitors of lymphocyte signaling. There are two types of drugs, which are cyclosporine and tacrolimus, and their mechanism of action are basically the same, whereby both of the drugs will inhibit calcineurin, and calcineurin functions in activating T cells of the immune systems. Thus, by inhibiting this calcineurin, it will prevent the activation of T cells, which will then suppress the immune system. So both of the drugs are indicated for patients with recurrent after stomatitis, oral lichen planus, and mucous membrane pemphigoid. However, they differ in their adverse reactions, which are for cyclosporine, hyperkalemia, gingival hyperplasia, gastrointestinal disturbances, headache, tremors, increased susceptibility to infections, and malignancy. And the route of administration can either be through oral and topical, and the doses are depending on the indication. And for tacrolimus, the adverse reactions are nephrotoxicity, neurotoxicity, gastrointestinal disturbances, hypertension, hyperkalemia, and also hyperglycemia. There are mainly administered topically in the form of ointment, and doses are also depending on indications. Okay, next is cytotoxic agents, which are antimetabolites or alkylating agents. Okay, first we go to antimetabolites. Drug example is azathioprine. And this drug works by inhibiting RNA and DNA synthesis by interfering with purine synthesis. It prevents adenine and guanine synthesis along with the inhibition of B and T cells. And this drug is indicated for various immunological diseases affecting the oral cavity, which include recurrent after stomatitis, oral lichen planus, pemphigus vulgaris, mucous membrane pemphigoid, erythema multiforme, and also Sjogren syndrome. However, with prolonged usage of this drug, it may cause bone marrow suppression, leading to various hematological problems such as decrease in red cell and thrombocyte count, which may then increase the susceptibility to infections and malignancy. So due to these reasons, precautions must be taken by performing complete blood count before and during treatment with this drug to monitor. And route of administration is through oral, and doses are also depending on indications. Okay, next would be alkylating agent, and drug example is cyclophosphamide. This drug is the most lethal to rapidly proliferating tissues, and cyclophosphamide works by adding an alkyl group to the DNA, causing damage to the DNA by cross-linking, thus causing cell death. So cytotoxicity of this drug depends on the degree of DNA alkylation, and it is indicated with patients with severe cases of pemphigus and pemphigoid. This drug may cause adverse reactions such as acute bone marrow suppression, gastrointestinal disturbances, and alopecia, which is spot baldness. And it is administered intravenously, and the doses are also depending on indications.
Okay, next I will continue with the cytokine inhibitors. In the inflammatory response, the activated macrophages will secrete the cytokines. Okay, under the cytokine inhibitors, there are TNF alpha inhibitor and also interleukin 2 inhibitor. Okay, first I will talk about the TNF inhibitors. Etanercept is one of the TNF inhibitors. The drugs will bind specifically to the TNF and prevent the binding of the TNF to its receptor, thus prevent the modulation of the inflammatory process. It is administered via subcutaneous injection and indicated for oral lichen planus and also oral ulcer in Behçet's disease. But it is contraindicated for patients with the risk of sepsis. The adverse effects are infection, especially upper respiratory tract infection. Second, injection site infection. It may cause erythema, itching, pain, and also bruising. Infliximab also one of the TNF inhibitors. It acts exactly the same as the previous drugs. It is administered via IV and indicated for recurrent oral ulcer, but contraindicated to the patient with TB and also patient with moderate or severe heart failure. The adverse effects are fever, dyspnea, diarrhea, and also fatigue. Okay, for interleukin 2 inhibitor, we have bexidicimab. It will bind to the interleukin 2 receptor and prevent the binding of the interleukin 2 to its receptor. It is administered via IV, and the indication is for oral lichen planus. The adverse effects are hypotension, tachycardia, diarrhea, and also fatigue. The last type under immunosuppression is inhibitors of immune cell adhesion. The drug's name is ifalizumab. The drugs will bind to the LFA1 and prevents the LFA1 ICAM interaction, thus preventing T-cell adhesion, trafficking, and also activation. It is administered via subcutaneous injection and indicated for oral erosive lichen planus, but contraindicated for patients with known hypersensitivity, and should not be used in patients with clinically important infections. The adverse effects are bacterial sepsis, viral meningitis, and also invasive fungal disease.
Okay, we have come to the next classification of immunomodulatory drugs, which is the immunostimulants. Immunostimulators are prescribed to enhance the immune response against infectious disease, tumors, and alteration in antibody transfer. So, based on the information that we have gathered, there are a few immunostimulant drugs that is used to treat oral diseases. Okay, so for the first drug is the levamisole, which is a heterocyclic compound. Levamisole is originally used as an anthelmintic, or also known as vermicide, which is an agent that destroys parasitic intestinal worms. But it appears that levamisole can restore depressed immune function of B lymphocyte, T lymphocyte, monocyte, and also macrophage. So for the indication of levamisole, it is used for aphthous ulcer, oral lichen planus, mucous membrane pemphigoid. And as for systematic use, it is an adjuvant therapy in combination with a 5-fluorouracil for after surgical resection in patients with stage 3 colon cancer. As for adverse effect of levamisole, patient would develop flu-like symptoms or have GI disturbance, have headache, dizziness, insomnia, thrombocytopenia, glycocytopenia, or patient could develop allergic manifestation and muscle pain. As for the mechanism of action of levamisole, first of all, the thymopoietin, which is a polypeptide hormone secreted by thymus that will induce proliferation and differentiation of lymphocyte into T lymphocyte or thymocyte. So the thymopoietin are usually targeted in a disturbed immune system. And when patient consume orally, the levamisole will mimic the thymic hormone and thus form thymopoietin mimetic tertiary structure, and then it will stimulate the lymphocyte. So for the doses, levamisole are taken according to indication. As for the pharmacokinetic, levamisole are taken orally, and it will be absorbed from the GI tract and metabolized in the liver, excreted mainly in urine. Okay, moving on to the second immunomodulatory drug used, which is Bacillus calmette-guerin, or known as BCG, vaccine. So this is an attenuated live culture of the Bacillus of Calmette and Guerin strain of Mycobacterium bovis. So this BCG vaccine, we will extract a strain called BCG-PSN, Bacillus calmette-guerin polysaccharide nucleic acid. So this extract will be injected into the patient. Okay, for indication of BCG, it is used for erosive oral lichen planus for oral diseases, but BCG vaccine is used in systemically for tuberculosis or any mycobacterial infection. BCG is highly contraindicated in immunocompromised patients such as HIV patient or organ transplant patient. So as for the side effects of BCG, it will develop severe skin swelling, or could have loss of appetite, weight loss, flu-like symptoms, and it could also cause swollen glands in the neck and underarm area. Since it will be injected to the skin, sometimes the skin will develop tenderness or small bumps.
Moving on to the third immunostimulant drugs, which is thalidomide. Thalidomide was first marketed in West Germany in the year 1957. A German drug company named Chemie Grünenthal developed and prescribed this drug as a sedative or hypnotic. It is also used for antiemetic. This drug is used for the treatment of morning sickness. Now, due to its immunomodulatory action, it is used for a number of conditions, including multiple myeloma, Crohn's disease, sarcoidosis, and rheumatoid arthritis. Its mechanism of actions include it modifies the cell-mediated immune response, it inhibits tumor necrosis factor alpha, interleukin 6, interleukin 10, and interleukin 12 productions. It modulates the production of interferon gamma and increases the production of interleukin 2, interleukin 4, and interleukin 5 by the cells of immune system. It increases lymphocyte count, co-stimulates T cells, and modulates natural killer cell cytotoxicity. The indications for thalidomide are for recurrent after stomatitis and for lichen planus. The contraindications for thalidomide are known hypersensitivity to thalidomide, pregnancy or breastfeeding, and if the patient aged below than 12 years old. For the adverse effect, thalidomide can cause edema, hypotension, headache, hematuria, arthralgia, myalgia, increase in the bilirubin production, peripheral neuropathy, dizziness, and paresthesia. Patients should undergo steps, which is system for thalidomide education and prescribing safety, before they are prescribed with this drug. The fourth immunostimulant drug is recombinant cytokines. This includes interferons and interleukin 2. Although interferons, which are alpha, beta, and gamma, initially were identified by their antiviral activity, these agents also have important immunomodulatory activities. Its mechanism of action include the interferons bind to specific cell surface receptor that initiate a series of intracellular events. The intracellular events includes induction of certain enzymes, inhibition of cell proliferation, enhancement of immune activities, including increased phagocytosis by macrophage, and augmentation of specific cytotoxicity by T lymphocytes. Interleukin 2. Human recombinant interleukin 2 is produced by recombinant DNA technology in E. coli. Its mechanism of actions are enhancement of lymphocyte proliferation and growth, enhancement of lymphocyte-mediated cytotoxicity and killer cell activity, and the last one is induction of interferon gamma activity.
Okay, so now we'll proceed the presentation with a case report. The case report that we have looked upon is about oral erosive lichen planus, or OLP for short, entitled A Case Report with a highlight on etiopathogenesis and immunomodulatory effect of tacrolimus, which is an immunosuppressant, in management of OLP, or oral erosive lichen planus. The history goes that a 50-year-old female complains of severe pain and burning sensation for the past 2 to 3 months. History of presenting illness started as back as low-intensity pain of the oral cavity 3 years ago, progressed to this state since 2 months ago. Patient was diagnosed with rheumatic heart disease and hypercholesterolemia 3 years ago and was on long-acting penicillin injection, and the frequency is 1 for every 20 days. She had undergone few restorations done in her teeth using silver amalgam She also had a root canal treatment with crown placement done with respect to a posterior tooth. Her oral hygiene status was moderate, and the patient had no deleterious oral habits. Upon clinical and intraoral examinations, diffuse lesions in the form of erythematous areas were seen interspersed within the white keratotic areas present all over the facial aspect of gingiva and more posteriorly on the buccal mucosa bilaterally. This can be seen clearly in the picture 1 and 2. The left and the right buccal mucosa showed a white erythematous patch measuring approximately 2 times 2.5 centimeters, extending anteroposteriorly from the area adjacent to the mandibular first molar to the retromolar pad area, and superior inferiorly from the line of occlusion to the upper and lower lingual vestibule. This can be seen in picture 3 and 4. Investigations has been done to determine the definitive diagnosis. Investigations include complete blood picture and hemogram, also biopsy. The results of the complete blood picture and hemogram shows that it was found to be within the normal limits. Although the biopsy reveals it is to be a case of lichen planus, as the photomicrograph, as in the H&E stain slides, shows a parakeratinized stratified squamous epithelium and a hyperplasticity in a few areas, indicating oral erosive lichen planus. Therefore, the final diagnosis was erosive oral lichen planus on facial gingiva and the buccal mucosa bilaterally. The treatment that is stated in the case report is the use of topical tacrolimus 0.1% immunosuppressant, which is the topical tacrolimus is a immunosuppressant, was prescribed thrice daily for 1 month, and then the dose was tapered to twice daily for 2 weeks after 30 days. This was continued for 2 months, and the patient was monitored continuously for 6 months. Also take note that oral leukoplakia and oral erythroplakia are well known to be precancerous lesions, while the malignant potential of oral lichen planus or OLP has been the subject of much discussion in the past few decades, which means that oral leukoplakia and oral erythroplakia are both the differential diagnosis in this case. Since the clinical and histological features of these white and red lesions are similar, differential diagnosis of them is important. Oral lichen planus has a characteristically bilateral distribution, typically involving the buccal mucosa, dorsum, and ventral surfaces of the tongue and/or gingiva, when it often presents as a desquamative gingivitis. The treatment aims of symptomatic oral lichen planus are to heal the areas of painful ulceration or blistering. Therefore, topical corticosteroid therapy is the mainstay of the treatment. Patients had been advised to the need to maintain a high standard of oral hygiene, and any causes of mucosal trauma, such as ill-fitting dentures, sharp cuts, and poor dental restoration should be eliminated. Patients had to be informed that there is a very small risk of malignancy associated with oral lichen planus, and that long-term monitoring may be appropriate. The use of tacrolimus in this case report shows that it shows a lasting improvement in the healing of the lesions. Tacrolimus, which is an immunosuppressant, is a microlide calcineurin inhibitor. Calcineurin is a calcium and calmodulin-dependent serine threonine protein phosphatase which activates the T cells of the immune system. The activations of T cells will increase the intracellular calcium, which in the presence of calmodulin is a catalyst that activates calcineurin. Tacrolimus acts at the dephosphorylation stage, thus obstructing it and bringing up phosphorylation. This ultimately decreases the activity of genes coding for various interleukins, which ceases the progress towards oral lichen planus-like lesions. And this picture in the slide is a simplified way to explain the mechanism of action of tacrolimus. Here are the references that has been used throughout the presentation, and with that, thank you.